have a 63-year-old man comes to the emergency department due to progressive dyspnea and fatigue, uh, not being able to lie flat due to difficulty breathing in his had to sleep in the sitting position, so paroxysmal dyspnea. Okay. uh, he had an anterior myocardial infarction 6 months ago, and he's not been compliant with his medication regimen since that time. Medical history is also significant for hypertension. Okay, the patient is an ex-smoker with a 30 pack year history. He doesn't use alcohol. His father died of heart attack at age 60. Okay, BP is 170 by 100 mm of mercury. Pulse is 100 per minute. Okay, and regular. Oxygen saturation is 90% on room air. He is afebrile. Auscultation reveals crackles at the lung basis. NS3 gallop sound. Okay, and 2 by 6 hollow systolic murmur for the apex. The patient is admitted to the hospital, and after treatment with diuretics and vasodilators, his condition improves significantly. Okay, 3 days later, there are no appreciable gallops or murmurs on cardiac examination. Which of the following best explains the murmur heard um, at the time of initial examination? Note this point that the patient is afebrile. Okay, so let us listen this. So option A, heavily calcified mitral annulus. Option B, increased flow velocity through the aortic wall. Option C, ruptured chordae tendineae. Option D, secondary mitral regurgitation. Option E, thickened and deformed mitral wall cusps. So pause it and give the answer. So the correct answer for this question is option D. Why? Because uh, this patient is presented with the decompensated heart failure, right? Which would have lead to this secondary mitral regurgitation. Let us see to the explanation, right? Is there saying this patient presentation with fatigue, aggressive dyspnea, orthopnea, pulmonary crackles, and a free heart sound consistent with decompensated heart failure. Appropriate treatment with diuretics, which would decrease load, and vasodilators, which will also decrease load. Okay, result in some dramatic improvement and disappearance of the apical hollow systolic murmur, which was most likely due to secondary, that is functional mitral wall regurgitation, right? Which is heard at the fifth intercostal space at the apex of the heart. Various primary mitral regurgitation is caused by intrinsic defect of mitral wall apparatus. For example, cleft in the wall cusp, myxomatous degeneration of the chordae tendineae. Secondary mitral regurgitation occurs due to other factors. For example, in this case, due to decompensated heart failure. So, decompensated heart failure is common cause of secondary mitral regurgitation because it leads to increase in the left ventricular and diastolic volume, right, or preload, uh, with dilation of the mitral wall annulus, the tissue on which the mitral wall cusps are mounted, and taut stretching of the chordae tendineae. Okay, so the dilated annulus and restricted movement of the chordae tendineae can cause insufficient closure of the intrinsically mitral, normally mitral wall, resulting in mitral regurgitation. Systemic hypertension can also contribute to secondary mitral regurgitation by favoring relatively lower resistance regurgitant flow. Treatment with diuretics to reduce left ventricular and diastolic volume and vasodilators to reduce BP can lead to resolution of uh, heart failure induced mitral regurgitation. Okay. Why not option A? Because calcification of mitral valve annulus may occur with aging, right? Can be accelerated by hypertension or advanced kidney disease. It is usually incidental finding that doesn't affect mitral valve function. So it would not affect mitral valve function. Okay. Why not option B? Increased flow velocity through aortic valve occurs with aortic valve stenosis. If there is aortic valve stenosis, uh, let's say over here, if there is aortic valve stenosis, then there will be increased flow velocity, right? Okay. Then the resulting murmur uh, is crescendo decrescendo and best heard at the right second intercostal space, but is there talking about at the apex of the heart, which is the fifth intercostal space on the left side. So not that's why it is not matching with that. So rather than the holosystolic and best heard at the apex, as I talked about this. Chorditendine rupture is potential cause of primary mitral regurgitation, right? That can occur in the setting of bacterial endocarditis, connective tissue disease, for example, Marfan syndrome, or acute myocardial infarction. The resulting murmur doesn't resolve with diuretics and vasodilators. Surgical repair is uh, typically required. And if you have noted, this patient is afebrile, so it couldn't be bacterial endocarditis, right? Because that is associated with fever, something like that. Okay. Then why not option E? Thickened and deformed mitral valve cusps can occur in RHD, rheumatic heart disease, another potential cause of primary mitral regurgitation. Such a murmur doesn't resolve with treatment of decompensated heart failure. Okay. In addition, mitral stenosis, evidence by snape, opening snape, and mid-diastolic murmur is more likely than mitral regurgitation to occur with rheumatic heart disease, right? So if there is rheumatic heart disease, that would be more likely associated with mitral stenosis, not with mitral regurgitation, and it wouldn't be resolved with treatment of decompensated heart failure. Okay, so decompensated heart failure is the common cause of secondary, that is functional mitral valve regurgitation. Increased left ventricular end diastolic volume causes dilation of mitral valve annulus and restricted movement of chorditendine with subsequent regurgitation. Treatment with diuretics and vasodilators can improve heart failure induced mitral regurgitation. So, in the next question, we have a 52-year-old man comes to the office due to a two-week history of progressive fatigue and exertional dyspnea. The patient is postal delivery worker and reports that he gets short of breath after walking a few blocks. He has not had chest pain or palpitations. The patient doesn't use tobacco, alcohol, or illicit drugs. Cardiac auscultation reveals a murmur that is best heard when the patient sits up and leans forward. Okay, he brings to the office the report from a recent cardiac catheterization graph shown below. Okay, the patient's murmur would most likely to be loudest at which of the following time points on the graph. So they have mentioned this graph, and with it they have named with A, B, C, D, E different positions. Okay, this is the pressure of atria, this one, right? And this is the they have mentioned this is the pressure of left ventricle, right? This one, and with that, this one is the pressure of left atria because low pressure. Okay, so then they have mentioned these options. Okay, let us listen this heart sound. So pause it and give the answer. The correct answer for this question is option C. Why? because this is the case of mitral regurgitation, aortic mitral regurgitation. Why? Because there is no diacritic notch. And with that, let us see further explanation, right? Okay. First, let me explain the normal. Okay. This is the atria. Whenever the uh, ventricular pressure is greater than atria, like just like in this case the pressure would be increasing than atria. So let's say, let me draw this for you. Okay, so if the ventricular pressure is increased than atria, so the valve will get closed. Okay, so over here mitral valve will close. Now whenever the pressure is increasing, right, and let's say they're talking about left side. Okay, so we are talking about left side. Okay, um, whenever the left ventricular pressure, just like here, is increasing than the aortic pressure, so this will open this aortic wall, right? And over here is the have mentioned the aortic wall opens, right? Then this pressure would increase, and then when on going down, when this ventricular pressure is again down than aorta, right, the aortic pressure, so that would again close that uh, walls. Okay, so aortic wall closes, and normally here is diacritic notch, right, over here we can see. So but in this case they have not mentioned just like that. And whenever this uh, ventricular wall ventricular pressure is going down, right, and when it again goes down below the atria, so the atrial pressure over here would raise, right, so this will again open this wall. So that's why they are saying mitral wall opens. Again over here mitral wall will closes, aortic wall opens, aortic wall closes, right, then mitral wall opens, right, so that this will be continued just like that. And if we note this the case of aortic regurgitation, right, over here the diacritic notch is not located, and this is more steeper, normally it is not just like that. Let us see the further explanation, right? This patient's cardiac catheterization shows hemodynamic profile consistent with aortic regurgitation. The characteristic decrescendo diastolic type murmur best heard with the patient when the patient leaning forward. Right, point to be noted. The peak intensity of the murmur occurs just after aortic wall closure, when the pressure created between the aorta and the left ventricle is maximum. That is 8.3. This pressure gradient falls progressively during diastole as blood regurgitates into the left ventricle, accounts for a decrescendo nature of murmur, right? If it was the case of stenosis, aortic stenosis, that would produce a crescendo type murmur, okay? But this one of diastolic type, that would produce decrescendo type murmur, okay? So notable changes to the pressure tracing that occur in aortic regurgitation, as I mentioned, loss of aortic diacritic notch, right? With that steep diastolic decline of aortic pressure, with that high peaking left ventricular and aortic systolic pressures. So loss of the aortic diacritic notch and the normal aortic pressure tracing, the diacritic notch is created by a small and abrupt increase in the aortic pressure as blood is secured in the aorta by closure of the aortic valve. However, with incompetent aortic valve, there is immediate backflow of the blood into the left ventricle, resulting in loss of pressure in the aorta and disappearance of diacritic notch. Steep diastolic decline of aortic pressure. Aortic diastolic pressure declines more rapidly than normal as blood regurgitates into the left ventricle and narrows it lower than normal level. Okay, with that high pressure, high peaking left ventricular and aortic systolic pressure. The left ventricle attempts to compensate for regurgitant backflow by increasing stroke volume, resulting in higher systolic blood pressure, which combined with low aortic diastolic pressure leads to a wide pulse pressure. This thing is important. they will produce a white pulse pressure because the systolic pressure will go up high, as we can see the systolic pressure would go very up high and the diastolic pressure would go very low. So as we know, the pulse pressure is the difference between them, so that would increase. All right, so why not option A? Why not option A? This point corresponds to the start of left ventricular contraction just after mitral valve closure and just prior to the opening of aortic valve. It would mark the onset of hollow systolic murmur of mitral regurgitation, right? So this is the case of mitral regurgitation. Like what would happen over here whenever, let me draw this for you guys. So if let's say if there is mitral regurgitation, this fluid will go in the backward direction, so that will increase the atrial pressure. So that's why over here we can see the atrial pressure has been raised, right? Why not option B? This is the peak systolic pressure produced by left ventricle during systole. The peak intensity of crescendo decrescendo murmur of aortic stenosis is heard here. If we look at this, right, uh, because if there is aortic stenosis, what would happen? This left ventricular pressure would be more increased than that of aortic pressure, right? So we can see this pressure has been very raised, but in normal cases this wouldn't be that much raised than that of the aortic pressure, like would be just like same over here, right? But little bit increase than that, not just like in this case, which is very huge difference. The point D corresponds to mid diastole. The murmur of aortic regurgitation is likely uh, here as well, but at lower intensity given the relatively lower pressure gradient between the aorta and left ventricle. The low pitch rumble of mitral stenosis would also be heard at this time, right? Mitral stenosis. So, because of that mitral stenosis, the aortic pressure would be increased more, right? Why not option E? Because this point marks the onset of left atrial contraction, that is atrial kick, just before closure of mitral valve. Accentuation of mitral stenosis murmur may be best heard at this time, that is pre-systolic accentuation. Okay, aortic regurgitation causes a decrescendo diastolic type murmur with maximal intensity occurring just after closure of the aortic valve when the pressure gradient between the aorta and left ventricle is the highest. The pressure raising of the aortic regurgitation is characterized by loss of the aortic diacritic notch, steep diastolic decline in the aortic pressure, and high peaking systolic pressure. That means the pulse pressure would increase, right? So two things to be noted: the diacritic notch would be lost, and with that diastolic, the pulse pressure would be increased, right? Okay, in the next question, we have a 67-year-old man is brought to the emergency department due to progressive shortness of breath. He has had decreasing exercise tolerance for several months, and over the last week, he could barely walk to bathroom without becoming short of breath. The patient has been sleeping in a semi-recumbent position recently. Okay, medical history includes type 2 diabetes mellitus, hyperlipidemia, and myocardial infarction 3 years ago. Okay, he takes no medications. The patient doesn't drink alcohol or use tobacco products. BMI is 30. Okay, kg per meter square. Oxygen saturation is 92% on the room air. The apical impulse is palpated in the sixth intercostal space along the anterior axillary line. There is 3 positive bilateral pairing edema in the legs. Which of the following most likely increase in this patient? Let us first hear this sound. Okay. So option A is arteriolar resistance, option B lung compliance, option C mixed venous oxygen content, renal perfusion, then stroke volume. So pause it and give the answer. The correct answer for this question is option A. Why? Let us see to the explanation. Because this patient with progressive dyspnea, orthopnea, lower extremity swelling, and laterally displaced point of maximal impulse has uh, decompensated heart failure. Heart failure occurs due to either progressive decline in myocardial contractility, that is systolic dysfunction, or impaired ability to, of the ventricular walls to relax during filling, that is diastolic dysfunction. Both etiologies eventually lead to decreased cardiac output and inadequate oxygen delivery to the tissues, right? Inducing the following neuroendocrine compensatory mechanisms in effort to restore organ uh, perfusion. Like the first one is increased sympathetic output. With that, the system which is working is RAS system. Okay, so these two things will be activated. So in case of increased sympathetic output, baroreceptors sense decreased perfusion, okay, that will stimulate epinephrine and norepinephrine release to increase heart rate and contractility. Okay, vasoconstriction is also triggered that would increase arteriolar resistance, that would raise afterload. Okay, so that's why, as we were saying, that there will be increase in arteriolar vasoconstriction. Okay, so in case of RAS system, decreased renal perfusion leads to increased secretion of renin and increased circulating level of angiotensin 2, right, which is a potent vasoconstrictor that would further increase afterload. Now, adrenal secretion of aldosterone would also increases, that would stimulate sodium and water retention, and uh, that's why increasing the circulating blood volume. That means preload, right? Although these compensatory mechanisms initially will improve organ perfusion, they are overall maladaptive. So they are not good in chronic case, right? A vicious cycle is generated as the failing heart is unable to pump against increased afterload and volume retention. Retention creates venous congestion in the kidneys that reduces glomerular filtration rate and further impairs diuresis. With that, atrial and ventricular stretch triggers release the natriuretic peptides that would stimulate vasodilation, fluid diuresis to counteract the vicious cycle. However, this is important. These effects are outweighed by the downward spiraling negative effects of sympathetic drive and RAS activation. So these will be ultimately not effective, right? Why not option B? Left ventricular failure leads to increased pulmonary venous pressure and transudation of fluid into the lung parenchyma, which stiffens the alveolar valves and decrease lung compliance. So the lung compliance would be decreased. What is the other condition in which lung compliance would be decreased? For example, chronic hypertension, right? Okay. Why not option C? With reduced cardiac output, the tissue become starved for oxygen and increase oxygen extraction from the available capillary bed. This leads to reduction in mixed venous oxygen content. So that would be decreased, right? Because there is increased utilization of oxygen, right? Why not option E? Stroke volume is generally maintained early in the heart failure. That would be maintained early, right? Due to compensatory mechanism. And decreases, and that would be decreases, right? The stroke volume would be decreases as decompensation take place, right? So decreased cardiac output in heart failure triggers neuroendocrine compensatory mechanisms to maintain organ perfusion. However, the compensatory mechanisms are maladaptive over the long term. Increased sympathetic output and activation of RAS stimulate vasoconstriction, volume retention, compounding the hemodynamic stress on an already failing heart, creating a vicious cycle of decompensation.